questions at the end. We'll have a panel discussion. So next, actually, again, it's my pleasure to introduce the next speaker, Dr. Boyle, who is assistant professor at UNMC from the Department of Surgery, Urologic Oncology. Her topic presentation is a fusion biopsy. Dr. Boyle.
So he was using the mouse, right? Great. Hi, and thanks for the invite. I know oftentimes urologists and radiation oncologists don't get into the same place. And I'm very excited to be at UNMC where we all work really well together. My objectives for this talk are actually pretty simple. I want to talk to you guys about MRI imaging of the prostate. And then I want to outline what a fusion biopsy is. I want to talk a little bit about what the procedure is. And I want to help you to understand what the results of a fusion biopsy are, what they mean. And then we're going to talk a little bit in broader terms about when we should use a fusion biopsy and what does the evidence show us about when it's appropriate to do that. So diagnosing prostate cancer happens from a transrectal ultrasound guided biopsy. We take a systematic 12-core biopsy of the prostate, and it's blind to what the tumor location is. And I want you to think about for a minute the fact that prostate cancer is the only solid organ tumor that is diagnosed without imaging guidance in the hopes of just accidentally hitting a tumor. I want you to think for a minute about if you approached a woman who you thought had breast cancer and told her you were going to randomly stick a needle in her breast 12 times and hope that you diagnosed her breast cancer. So I think we've talked a little bit with some of Dr. Ink's slides about the importance of prostate cancer. And prostate cancer has a bit of an interesting story in that the advent of PSA took the incidence of prostate cancer up quite high. And you can see that again here. And the interesting thing is that it really didn't have an effect that they saw on the mortality of prostate cancer. So I think Dr. Ink's slide was actually a year better than mine, so we'll skip that one. And I want to go back to our method of detecting prostate cancer. And I want you to think for a moment, if the gray spot here was a Gleason 3+3 tumor, clinically insignificant prostate cancer, and all the red dots were other forms of more clinically significant prostate cancer. I want you to recognize that the needles have missed any of the clinically significant prostate cancer. So where do we go with this? And probably about 10 years ago now, they started to look at the use of multiparametric MRI in prostate imaging. And we used to do this with an endorectal coil. And as you see here on the T2 weighted images, there's a dark area which represents a tumor. And on the DWI, you can see that there's an area here which is highlighted with the red arrow. And then our DCE, it lights up like a little Christmas tree. And so those are the types of characteristics that they were seeing on MRI. And so then the question becomes, do these areas correspond to anything? Are we able to say anything? And in order to be able to use our MRI to guide our biopsy, we needed a way to marry those two. And so they came up with a fusion guided image. And what happens is you take the MRI image and you align it with your real-time ultrasound. And so you can see here that you don't see anything on your ultrasound image, but we do on our T2 axial, and this is an anterior tumor. And so what they did was they had our colleagues in radiology place a target over this area on the MRI, and we fuse the image, and we're able to just draw that target in a cartoon, and it appears just like it does here. And then you can aim your biopsy in the direction of where those are. And you can see this is an image that we used to use quite frequently at NIH. These capture not only the area that is highlighted as being probable tumor, but it also captures our biopsy cores and the locations of them. And what were they able to show? They were able to show when they correlated with whole mount histopathology. So what they did was they marked the MRI images, they did the fusion biopsies, and then they took out the prostates, and they used a special mold to slice it and find exactly where we took the biopsies and see if we could actually correlate the location of the tumor with the whole mount visualization of the tumor. And you can see that there's a ton of publications that came out from this between sort of 2009 and 2012. So now we can prove that we can find it, and we can show that the characteristics we're identifying on MRI are really, truly correlating with our pathology. So once they did that, they also went ahead and we started using the targeted biopsies. And so you see here, this is our fused image, which allows us to guide our biopsy. There's several different platforms. And they, again, were able to publish a bunch of papers showing that these targeted biopsies really were hitting the tumor in the area of the MRI was highlighting as being important. This is what it looks like when I do it. This is our blurry MRI image that we usually get. And you can see they put a little target, literally a target, and you use that to guide your ultrasound image here. And then when you take your biopsy, you can capture where that biopsy is going. This can be really helpful if you're following patients with active surveillance and you want to repeat biopsy in the same area you previously biopsied. We're actually able to ask our radiologists to go in and mark those areas. So when we do this, what does it tell us? And where do we go with this? And there's a lot of papers documenting that the prostate biopsies that we get with fusion-guided biopsies are actually hitting the targets and they're getting what they want to get. The next question that became obvious was, how do we rate these? And they've come up with a system, it's appropriately called PI-RADS, and it's modeled after the BI-RADS system for breast. And what they wanted to know was, when we rate these on MRI, is that correlating with anything pathologically? And it turns out it is. The degree of suspicion we have for how bad a lesion is on MRI actually correlates to how bad it is pathologically. And so this is really important. When we look at low suspicion MR findings, we find that more often than not, if we diagnose something, it's a low risk prostate cancer. And similarly, when we see a high risk suspicion on an MR, we are getting high risk prostate cancer. And this is important because our imaging isn't just identifying, hey, there's something here we need to look at. It actually gives us an idea of how concerned we should be. So when we go ahead and we use an MRI fusion-guided biopsy, does it improve anything? Does it change anything in the world of prostate cancer? And so the question that they attempted to answer here was, how well does it correlate, and how are we doing with this? And again, they were able to reflect the same thing, that the suspicion on MRI really correlates with the pathology. And when we look at patients who have had a previous random biopsy, and we know that their PSA is still going up, there's always a question about what do we do with these patients. And so this was a really easy population for us to say, hey, look, we've got this MRI fusion biopsy. Will this help us to find these hiding prostate cancers in these patients who've had a previous biopsy? And so we went ahead and looked at that. And this was a pretty, it's a pretty stringent protocol that they follow at the NIH. First, you measure the prostate, you do your standard templated biopsy, then you fuse the images, and then you go ahead and take your fusion-guided cores. And what they found is, in patients who had had a previous biopsy that was negative, they were able to identify 21 high-grade cancers. These are Gleason 8 or higher. And what they found was that using the MRI targeting, they were able to detect 100% of those. However, if these patients had simply received another ultrasound-guided biopsy, they only would have detected 10 of them. And so I think that that's actually a really important thing, because we are missing a lot of cancers with random biopsies. And what they found was that, interestingly, The patients who'd had more negative biopsies had a much higher risk of us not only finding a high-risk prostate cancer, but finding one that is Gleason 8 or higher, and not just some of the lower grade, which are in green and yellow here. So when we compare these two modalities, because of course it's great to have it approved in that setting, but what do they do in comparison to one another? What if we look at them both? And so this was published in JAMA, and I think this was a really great study, aside from the one glaringly obvious detail that they decided to use the definition of high risk as being Gleason 4+3 or higher. But aside from that, I thought it was a really interesting way of comparing this. And they had a really good patient cohort of over 1,000 people. They were able to get prostatectomy specimens on 170. And what they were able to show was that if you did a standard biopsy, shown at the top, or an MRI biopsy, because all of our patients got both types of biopsies. And so if you compare them, you can see that the standard biopsy diagnoses a lot more Gleason 6 prostate cancer than a fusion biopsy. The second thing that this showed is that the high-grade cancers were higher in the targeted biopsies than they were in the standard fusion-guided biopsy. And so this actually suggests to us that our MRI fusion biopsy may be doing a better job of finding clinically significant prostate cancer that needs to be treated. And in fact, it may actually reduce the number of patients we find with clinically insignificant prostate cancer and reduce that burden of knowing that they have a cancer, even if it's a cancer that doesn't need to be treated. And this is another way of showing this. If you only did a standard biopsy, these are the cancers you would miss. And so you can see here that the standard biopsy would actually miss all of these red and yellow cancers that should be found, because they do change our management and they change our treatment. Whereas the fusion biopsy really just missed a lot of low-risk prostate cancer. And arguably low-risk prostate cancer is something that we maybe shouldn't be looking for. So when we summarize the results, their summary says that targeted biopsy diagnoses 30% more high-risk prostate cancer. And again, take it with a grain of salt, that's Gleason 4+3 and higher. And it diagnoses 17% fewer low-risk prostate cancer. I think that's really important. The MRI targeted biopsy also, as one of their secondary endpoints, it was better at predicting the whole gland pathology. So back when I started practicing urology, you know, we took out everyone's prostate. I mean, you got a little bit of Gleason 6, I'm in there, I'm taking out your prostate. And one of the reasons we did that is because there was a 30% chance that after I took out your prostate, I was gonna come back to you and I was gonna tell you, I thought you had Gleason 6, but actually, we found some Gleason 9 in there, or we found some Gleason 7. And so that upgrading risk was not insignificant. And now when we look at a fusion-guided biopsy, it is. It's very insignificant. In fact, the discordant rate between biopsy, when you do a fusion biopsy and final pathology, is very, very low. And we did some research here at UNMC that actually has been presented at a few conferences. I'm still waiting for the resident to write it up. So one of the other questions that they raised was, what's the utility of a 12-core random biopsy when we add it to a fusion biopsy? And so they were able to calculate this out, and they calculated out that you would need to do 200 extra standard biopsies on top of the fusion in order to diagnose one additional high-risk prostate cancer that you missed with fusion biopsy. Now, I think there's some, I have a few concerns about the way they calculated this, and that's only because I worked at the NIH, so I know the population very well. Nonetheless, I think that the calculation itself stands. You have to do an awful lot of biopsies on patients with random biopsies on top of their fusion biopsy if you actually want to find another high-risk cancer. So one of the questions I had when I moved here to Nebraska was, what about our population and what about biopsy naive patients? Because that's a population that the NIH doesn't see very often. And so I actually pulled our cohort analysis and I looked, how well are we doing in patients who've never had a biopsy before? These are the ones that insurance fights me on tooth and nail. And so my goal is to get this out there so that we can prove that it's actually better. And so I went ahead and looked at our population, and sure enough, the targeted is significantly better at diagnosing clinically significant prostate cancer than a standard biopsy. And this holds true for every PSA that we looked at. However, the PSA at which the difference becomes clinically or becomes statistically significant is 4.3. I actually think that this is just a size problem, and if I had a bigger population, I could show you that it's true at every single time point. Nonetheless, I would argue that the difference between a PSA of 4 and a PSA of 4.3 is clinically insignificant, and that probably what we're looking at here is that a fusion biopsy is better than a standard biopsy at all PSAs, even in a population who's never had a biopsy before. So in conclusion, I hope that I have managed to highlight that prostate cancer remains a clinically significant problem, and that PSA screening alone, it results in a lot of biopsies and a lot of overdiagnosis. That doesn't mean we should throw out the baby with the bathwater and stop looking with PSA, but it does mean we need to be smarter about how we're doing that. And I think prostate cancer is the only solid organ cancer where we're just randomly sticking things in. We need to start looking at image-guided biopsies. And MRI fusion is a useful tool. I think that the fusion platforms can improve the detection of clinically significant prostate cancer and actually reduce the number of false negative biopsies. I think that all repeat biopsies, as a general rule, should be considered for fusion biopsy strongly. And I think there's growing evidence that biopsy-naive patients will benefit from a multiparametric MRI and a fusion biopsy. Thank you. No talk would be complete if I didn't say thank you to one of my mentors and one of the people who trained me. So for those of you who don't know who this is, it's Peter Pinto. He works at the NIH. He actually helped develop some of the fusion technology that exists today. This is Baris Turkbey. He taught me what an MRI of the prostate should look like and taught me how to look at them myself, which I think was really important, and a whole host of other really awesome researchers at the NIH. Thank you.